First, we'll talk about how we have come to define preventive cardiology, as the field has had somewhat of a identity crisis over the past few decades or so. Provide a historical context as to where we've come from. We'll talk about the various ways that we assess downstream risk, including risk equations, biomarkers, and imaging. And then we'll talk about some of the newer therapies we have, not just within the lipid space, but outside of the lipid space, and end on gene editing, something that's very exciting coming to the future. I have no disclosures. So this is a clinical practice statement that I was very fortunate to chair that came out in 2022 as part of the American Society for Preventive Cardiology. So prevention doesn't have a board just yet. It's something that we've been working on for a long period of time. We don't necessarily have a certificate to say you are a card-carrying preventive cardiologist. And so we thought that within the ASPC, the first step is try to just sort of unify us and come up with a unified definition. So after a lot of back and forth, this is what we came up with. It's a proactive, patient-centered approach in which the clinician or team of clinicians and non-clinicians, because it's multidisciplinary, and then the focus here is assessing cardiovascular disease risk and implementing strategies to mitigate that risk to prevent downstream cardiovascular diseases, plural, not just atherosclerosis, but holistically all cardiovascular disease, as well as its clinical sequelae. So when we think about prevention, we have three sort of broad general buckets. The first of which is primordial prevention. I remember learning about this as a fellow and thinking, what the heck is this? This is actually the gold standard, in my opinion. This is where you can make the most impact. Primordial prevention is the prevention of risk factors. That is the prevention of hypertension, the prevention of obesity, the prevention of diabetes. So traditionally, this has been the land of the pediatrician. And then next, we have primary prevention. That's maybe where lots of internists, internal medicine lives. That's trying to prevent a first event. So that's a first heart attack, first incidence of heart failure, for example. And then at the top is secondary prevention, and this is where cardiologists live. This is treating patients that have existing cardiovascular disease, have already had a heart attack, already have heart failure, AFib, and try to prevent a secondary or a second event. But preventive cardiology spans all three of these risk buckets because you can be high risk primordial prevention, you can be high risk primary prevention. Secondary prevention is already very high risk. But you can have, there are various things that you may want to focus on depending upon where you are in the life course. So to understand preventive cardiology, we have to talk about the Framingham Heart Study. The Framingham Heart Study was spurred by the increase in cardiovascular disease deaths that started in the first half of the 20th century. And it was developed by what is now the NHLBI. So it started recruiting in 1948. And the purpose of this study was to understand the natural disease progression of coronary heart disease and atherosclerosis, not just the natural progression, but what are the risk factors that go along with cardiovascular disease. So as I mentioned, it started in 1948. And it measured a whole bunch of biomarkers, blood pressure, anthropometrics, lifestyle information. What are people eating? How much are they exercising? Now, over time, the cohort grew old and they developed cardiovascular diseases, things like MI and stroke. And Framingham is still ongoing. And because it started so early, there have since been two generations. We have the Framingham Offspring Study, which are the kids of the original cohort. That started in 1971. And now we have a third generation that started enrolling in 2002. And so there's been additions over time as well to Framingham. We have more than just blood pressures and cholesterol numbers and how much are you exercising, what are you eating like. We have lots of biomarkers, novel biomarkers. We have imaging, cardiovascular imaging, CT, MRI, echocardiography. More recently, and this is, I think, especially pertinent to the generational disease risk model is, what are the genetic determinants of cardiovascular disease? So we have genome-wide association studies, DNA methylation studies, as well as omics data to try to understand outside of our traditional risk factors, what is driving events. So this is maybe one of the most important publications in my world, and this is the first outcomes data that we have from the Framingham Heart Study. This is a picture of Bill Cannell. He was the director of Framingham in 1966, and he published these, quote, factors of risk in the development of coronary heart disease. This is the seminal paper that coined the term risk factor. So this is where risk factors come from, is this study. And over the course of about 5 to 10 years, he showed, using what we use commonly in epidemiology now, regression analyses, that high blood pressure, high cholesterol, LVH on an ECG, also physical activity, smoking, and diabetes are associated with cardiovascular events. So it's Bill Cannell's seminal work for which we know what the drivers are of cardiovascular disease. So let's fast forward a little bit here now. We know that high cholesterol is associated with disease. In 1974, Doctors Brown and Goldstein developed the LDL, or I should say discovered the LDL receptor and its importance in cholesterol metabolism. Fast forward a little bit further, we have our first statin approved by the FDA. That's lovastatin. It's not on this graph, but that happened in 1987. But the first big statin megatrial was the 4S study, which was simvastatin. And that showed a reduction in all-cause mortality, the first statin to show that. So go along a little bit further in the spectrum, we have PCSK9 inhibitors. And the discovery of PCSK9 inhibitors was actually after we did genetic analyses, genome studies of patients with familial hypercholesterolemia implicating the PCSK9 gene in FH. Well, a little bit further down the line, we found there was another family, which was from the Dallas Heart Study. And those were patients that had low LDL cholesterol and low events. They sequenced those patients and those family members and found that there was also a variant in the PCSK9 protein, but this was actually a loss of function mutation. So these were people that had low LDL cholesterol over the life course that had something to do with the PCSK9 protein. So it was this seminal work from Dr. Helen Hobbs, who worked in Brown and Goldstein's lab actually as a trainee, that led to the idea that you can target PCSK9 therapeutically to have low LDL cholesterol and thereby lower events. And so it is that identification of information that led to the development of evolocumab and alirocumab, and now we have inclisiran as well. Okay, so why am I talking about all this stuff? Well, it's because we've been doing a pretty bad job here recently at preventing cardiovascular disease. Now, if we look at 1900 on to about 1970 or so, events were going up. Again, this is partially why the Framingham heart study was developed. But somewhere around 1970 or so, we started to do better. We saw reductions in cardiovascular disease deaths. And somewhere in that time is when statins came into play. So we were treating patients a little bit better. We had a better understanding of the risk factors. But if we look a little bit more proximally, somewhere around 2010 or so, cardiovascular disease deaths have stalled and are now on the rise again, which is very troubling. So we're doing a bad job. And then the question becomes, well, we have all of these great drugs. What is driving cardiovascular disease events here more proximally? Well, it's two things. It's obesity and diabetes. Of course, we still have all of our other risk factors. We have things like we have hypertension, physical inactivity, but these are the two biggest risk factors more contemporaneously that are driving events here. So I think you guys can see that marker there. Great. So the top graph is looking at some trends over time in obesity. And if we look at the top overweight category, stable, maybe a little bit better over the past 10 years or so. But if we look at obesity and severe obesity, there's a sharp rise over time in this risk factor. So what about diabetes? This is looking at type 1 and type 2 diabetes. Now, this is specifically in the pediatric population. This is ages 19 and younger. And this is just to illustrate that our risk factors are happening in younger patients now. And that risk factor will propagate over time, and it makes it probably more and more difficult to sort of reverse those risk factors, improve upon those risk factors over time. And so this is type 1, type 2, and this is broken down by different racial ethnic groups. And you can see the worst happens to be in the Native American population and also the non-Hispanic Black population. Okay, so next let's talk about risk assessment. And we'll start with the pooled cohorts equations. So the pooled cohort equations, or the PCE, was developed by the ACC and the American Heart Association. It came out in 2013, and this overtook Framingham. So our very first calculator was Framingham, and that gave you a 10-year risk of specifically coronary heart disease. So the PCE improved upon Framingham because it was derived from more data. We had 5 large cardiovascular population cohort studies. We had ERIC, the cardiovascular health study, Cardia, Framingham, and then the Framingham offspring study that went into the development, the derivation, and the validation of this risk calculator. So there's actually 4 equations in the PCE. We have one for men, one for women, but we also have one for Black and white. So between the combinations, you actually have 4 different risk calculators. Now, this is what the risk calculator looks like. I would imagine many of you have used this. This is what I learned when I was a trainee. But the pooled cohort equation is not always right. Some of the strengths, it has broader generalizability compared to the Framingham risk score. But the weaknesses, I think, are substantial. So some of the weaknesses are, number one, it has race-based adjustments, and there's always potential for bias when considering race. It can overestimate or underestimate in certain populations. So, for example, it overestimates risk in East Asian populations like Japanese people. Maybe more importantly, it underestimates risk in a large swath of people, specifically South Asians. So it doesn't do a very good job at understanding risk in those groups. It has a relatively narrow age range. I say relatively narrow. It starts at age 40, so it's not very useful in younger patients that are, say, in their 30s. And then it only gives you a 10-year risk. So, if you're 50, 60, 70, 10-year risk is important. But if you're 30 or 40, 10-year risk doesn't really matter as much. You want to know what your 30-year risk is, maybe your 50-year risk of events. So there's some limitations here. So enter Prevent. Prevent is the newest risk calculator that comes from the American Heart Association. And this was developed for several reasons. It was developed to try to overcome some of the nuances and weaknesses of the pooled cohort equation. It was developed from a more contemporaneous data set, more patients with obesity and diabetes, so it's more representative of what is going on right now. It's comprised of 46 observational cohort studies, including electronic medical record data sets. So that's an improvement from 5 with the previous one. It has more than 6 million patients that went into the development, derivation, validation of this study, of this equation, which is an improvement of 24,000 from the PCE. So a major upgrade. So this is what Prevent looks like. I have the website down there. And there's a few things that I want to focus on with Prevent. First and foremost, it starts at age 30 as opposed to age 40. So it works for our younger patients. You'll notice that there's no LDL cholesterol in Prevent, and that's because the lipid-related risk marker that this equation uses is actually the non-HDL cholesterol. That's the total cholesterol minus the HDL cholesterol. And we know that non-HDL cholesterol tracks with risk better than LDL cholesterol. So that's one improvement. We have the systolic blood pressure, the BMI. We have some more cardiometabolic markers in this risk calculator. We have an eGFR. And then if you go to the bottom, there are 3 additional factors that you can put in, but you don't have to personalize your risk even tighter. So we have a urine albumin creatinine ratio here. You can actually input the A1C, so it will factor into account how well controlled the diabetes is. And then down here, this one I think is particularly interesting. This is the zip code. You can actually put in the zip code for the patient. And this is a marker of what they're calling the social deprivation index. This is actually taken from some of the UK risk calculators. And the idea here is they wanted to include some sort of marker of SDOH, social determinants of health. Now, you can argue that there's lots of variability within a single zip code. So there's some controversy around this particular marker, but you can really hone in on risk based off of where you live now with this calculator. So I mentioned the strengths. There are still weaknesses with Prevent, and I think the weaknesses are somewhat substantial. First of all, maybe the biggest limitation in the scare is that there's potential for underestimating risk in patients and thereby not treating patients with statins. What we know from some of the early data in PREVENT is that it generally calculates 10-year risk at about half of what the pooled cohort equation tells you. So, for example, let's say you have the PCE gives you a 10-year risk of, say, 12%, which is in the statin eligibility range. If you were to do PREVENT, it'll give you a 6. And that's sort of your gray zone there. So there's potential for undertreating patients with PREVENT right now, which is a big concern. One thing I didn't mention is that it totally excluded race. And the reason is because race is a social construct, and they didn't want that as part of their risk calculator, but that's still somewhat controversial. It still requires a lot of real-world validation, and it's unclear what the threshold is as far as statin eligibility. So those prior studies that I mentioned were using the same thresholds for statin eligibility from the pooled cohort equation, but it's very likely that those thresholds are not accurate with PREVENT. So the ACC and AHA are now coming out with new cholesterol guidelines that is ongoing right now, and is that new guideline that will determine what the threshold is for statin eligibility. So we don't have the answer quite yet. So next, let's move on to biomarkers. Lp(a) is quite a hot topic. This is an LDL-like particle that has both an ApoB100 as well as an apolipoprotein A. It carries cholesterol ester as well as oxidized phospholipids. This is what makes this particle unique and uniquely bad. We think it's the oxidized phospholipids that make it such a nasty particle as far as its ability to induce cardiovascular diseases. It is greater than 90% genetically determined. We think it's inherited in an autosomal codominant fashion. So if you find an individual with an elevated Lp(a), you should screen all first-degree family members. So levels are stable throughout the life course. So it's not something that we generally repeat because it stays the same. It goes up a little bit after menopause, and there's some variability by race and ethnicity. So we know that in African Americans, for example, Lp(a)s are slightly higher than non-African American groups. There's not a lot of things that change Lp(a). Lifestyle factors don't meaningfully change Lp(a) levels. Statins don't decrease Lp(a). In fact, statins may increase Lp(a) modestly, but that's not a reason to not use a statin. It can be measured in 2 different ways, milligrams per deciliter or nanomoles per liter. We prefer the nanomoles per liter assay. We think that's a better assay, and that's what we use here at Medstar. And maybe most importantly, there's very good data, observational, Mendelian randomization, GWAS studies that all support the causal role of Lp(a) in the development of various cardiovascular diseases. This is independent of LDL cholesterol. This is an independent risk factor for cardiovascular disease. So what do the guidelines say about Lp(a)? Well, the short answer is that every guideline except for the ACC/AHA recommend that everybody should have an Lp(a) checked once in their life. The ACC/AHA is a little bit behind the 8 ball. They always are. We think that in the new cholesterol guidelines, they're going to have the same recommendation, so it's consistent throughout all the other major medical societies. And the reason that we recommend this is because high Lp(a) is extremely prevalent. 20% of the population has elevated Lp(a) levels. That's 1 in 5. And so because this is an additive risk marker, this is why so many societies are recommending that everybody gets this checked once. And this is what I do in my practice. So the next question becomes, well, what constitutes elevated Lp(a)? Now, this has actually been a moving target. We used to think that we had sort of a blanket greater than 50 milligrams per deciliter or greater than 125 nanomoles per liter constitutes elevated Lp(a). But the thinking has changed actually over the past 5 or so years. So this bar graph comes from the UK Biobank. And really what it shows you here is that risk is continuous and it's actually log linear. So you can't just neatly say risk increases above or below a certain threshold. And so this is a statement that comes from the European Atherosclerosis Society, and they actually recommend sort of a low, medium, high risk group. And so if you're measuring, I'll just talk about nanomoles per liter, which is what we have here at Medstar. Less than 75 is considered low risk, moderate is 75 to 125, and anything above 125 is considered high risk. And this is probably the best way to think about Lp(a). So what is the risk associated with Lp(a)? This is a nice sort of summary slide that comes from this nice review in The Lancet by Borg Norsgaard. So this is comparing Lp(a) at the top 5th percentile versus a normal Lp(a), controlling for all of your other risk factors. And what you can see here is that you see an increased risk of threefold for MI, aortic valve stenosis. This one is very interesting. PAD, twofold increased risk, heart failure, 1.7, ischemic stroke, 1.6, cardiovascular death, 1.5, and all-cause mortality, 1.2. Now, so what do we do about this? How do we incorporate this into our clinical practice? Well, like I said, at this point in time, we don't have any targeted therapies. Statins increase Lp(a) ever so slightly. However, there are some drugs that have some off-target effects for Lp(a). So PCSK9 inhibitors lower Lp(a) by about 20 to 30%. Now, is that clinically meaningful? We don't know that yet. So right now, Lp(a) is just a risk-enhancing factor. If you have a patient with high Lp(a), you should treat them aggressively for all of the other modifiable risk factors. But there's hope. So this illustrates some of the drugs that are in late-stage clinical trials that target Lp(a) specifically and lower it quite substantially. The first one on the left is pelacarsen. Pelacarsen is an antisense oligonucleotide. It lowers Lp(a) by about 80%. This is data from the Horizon trial. So Horizon was actually supposed to read out this year, which is a MACE trial, major adverse cardiovascular events. And unfortunately, they pushed the outcomes to next year, which I think is a little bit concerning. I think that can be interpreted in many different ways, but we're still waiting to see if lowering this biomarker reduces events. But even if pelacarsen is negative, the next three, olpasiran, zerlasiran, and lepodisiran, this is a newer technology. This is different. This is an siRNA. And these lower Lp(a) by almost 100%. Extremely potent drugs. So we're hopeful that even if pelacarsen doesn't work, maybe some of these siRNAs will. And then at the very end of the spectrum here, we have a pill. This is a small molecule pill, muvalaplin, a little bit more modest in its ability to lower Lp(a), but for those folks that don't like infusions or injections, there are pill forms coming down the road as well. Okay, so next let's talk about calcium scoring. What the AHA and the ACC will tell you is that calcium scoring is best used when risk is uncertain. Well, when is risk uncertain? For the most part, it's these middle two groups here. If you have an LDL above 190, you probably have familial hypercholesterolemia. That buys you a statin. If you have diabetes, that buys you a statin. Outside of these two groups in the primary prevention space, this is how we determine whether or not a patient should be on a statin. So if you're low risk, you're low risk. If you're high risk, you're high risk. It's these two groups here where the guidelines say you should consider using a calcium score. So what is the calcium score? I'm sure many of you have used this in your practice. The calcium score is a chest CT scan. It's a very low radiation. It's about 1 millisievert. And really what it's telling you is the total amount of plaque, specifically calcified plaque. It doesn't tell you non-calcified plaque, how much calcified plaque you have in your arterial tree within the coronaries. So a score of 0 is the ideal. That means you're low risk. And for the most part, you don't need to be on a statin, although there's some caveats there. And then we have mild, moderate, and severe, and that number can go up to infinity. So the more CAC you have, the more calcified plaque you have, the higher the risk you are, the more intense you want to be with your preventive therapies. So one thing just to mention and harp on a little bit more here is that the calcium score should really only be used for patients that are not on a statin. The guidelines recommend against doing calcium scoring for patients on a statin, and that's because statins raise the calcium score. Well, so then the question becomes, well, that sounds bad, right? You don't want to have a high calcium score. Well, that's because the calcium score is made up of two different components. There's a volume score and then a density score. And those two components of the score are inversely associated with risk. That is to say, a dense calcified plaque is a protective plaque. That's a safe plaque. That's a plaque that's not going to rupture and cause a heart attack. So mechanistically, yes, statins lower cholesterol, they increase the LDL receptor, but what they do to plaque is they form a safer, denser, thicker plaque that makes it less prone to rupture. So if you have a patient that's been on a statin for a decade and you do a calcium score, the score is going to be high. We know the score is going to be high, and that means the statin is doing its job. So you can't really interpret the calcium score for a patient that's already taking a statin. So another question that comes up quite frequently with calcium scoring is, well, what if I get a patient that has a calcium score of 1,000, 5,000, 10,000? I've seen some in the 10,000s. Do they need to rush straight to the emergency room? Are they going to die tomorrow? Well, the answer for the most part is no, they don't. And this is some guidance from the National Lipid Association that's trying to answer this question because it comes up all the time. And what they say here is that a high calcium score should not routinely trigger downstream stress testing in those asymptomatic individuals who report a normal functional capacity. There's really no data to support the benefit of coronary angiography or stenting in asymptomatic individuals with high calcium scores, including those that are demonstrated to have an ischemic response to exercise testing. Now, that last part comes from the ischemia trial, which basically showed that even with obstructive disease, stenting on top of really good medical therapy doesn't reduce events. So the calcium score doesn't tell you stenosis. With an asymptomatic individual, it should not just blanket lead to any downstream testing. It's not useful. There's no data to support that. So let's jump forward a little bit. We know the calcium scoring works pretty well. We use it to decide on which patients need a statin. Well, now we have AI, right? AI is everywhere. It's being incorporated in everything in medicine. So this is a group from Stanford, David Marin's group. And here they wanted to see if an AI-generated calcium score on chest CTs that are ordered for whatever reason, patients that come into the ED want to rule out PE, lung cancer, low-dose chest CT. Can you use that existing information, unleash deep learning AI to see, does the calcium score from this AI algorithm predict events like a dedicated calcium score? And what they showed was that it does. It works pretty well, actually. If we go to the results here for this study, they had about 5,600 or so patients that they quantified the calcium score on chest CTs, and comparing a deep learning calcium score of 100 or above to a 0, it predicts events just like a dedicated calcium score for all of the relevant cardiovascular outcomes here. So really what this tells us is that we can use AI to predict events just like we would a dedicated calcium score, using information that is already available in the electronic health record. Well, so then the next question becomes, can we use that information to change management, right? So this is the follow-up study from the same group at Stanford, David Marin's group, and this is called Notify-1. This came out in Circulation a few years ago. So in Notify-1, they had about 2,000 patients that had chest CTs for whatever reason. These are non-ECG gated. They excluded patients with existing disease, and they excluded patients that were already on a statin. And so they randomized them to 2 different arms, the first of which was just the usual care arm, the second of which was a notification arm. So within this arm of the study, they told the patient their calcium score and the doctor their calcium score to see, is that going to change management? And what they found at 6 months was that within the notification arm group, there was a 51% increase in statin utilization. And this is also appropriate statin utilization versus the usual care arm, 7%. So I think this is really compelling data. And this is actually coming to Medstar. We've been working on this for many, many, many months now, trying to figure out what is the appropriate language. But this is information that's readily available in our electronic health record. And if we do it right and we unleash this at scale, this can really be a powerful tool in shared decision-making to get people on the right therapy and lower events. So imaging guides prevention. These are just a few quick meta-analyses that have demonstrated that the identification of calcifications on a chest CT leads to an increase in both initiation and continuation of lipid-lowering therapies and all the other therapies. It leads to improvements in lifestyle, aspirin use, blood pressure medication use, etc. That's on the left. On the right, this is a meta-analysis looking at visualization of the plaque. So this is where the doctor shows the patient, this is your calcium score. Here's your chest CT. All the white stuff means plaque. So actual visualization of plaque also leads to decreases in their overall risk score, and then improvements in things like blood pressure and cholesterol. So imaging is a very powerful tool to change management. Well, some of the newer things on the docket here is plaque analysis or plaque assessment. So a few studies I want to highlight here quickly. Plaque analysis tells you two things above and beyond what a coronary CT will tell you. It will tell you total plaque volume as well as high-risk plaque features. So this study, this is some data from the Western Denmark Heart Registry, 24,000 patients that underwent a chest CT scan, coronary CT scan for chest pain. And then they stratified by obstructive or non-obstructive coronary disease. So overall, what you would expect, those that have obstructive disease have higher event rates compared to non-obstructive disease. But when you stratify by the total plaque volume or the total amount of plaque via the calcium score, these two event curves, regardless of your CAC category, are right on top of each other. So the interpretation here is that stenosis, luminal stenosis, does not predict events above and beyond total plaque burden. Well, what about high-risk plaque features? Similar sort of study. This comes from Scott Hart, and I just want to focus here on non-obstructive versus obstructive disease. So within non-obstructive disease, if you have adverse plaque features versus not having adverse plaque features, you have higher event rates. Same thing holds true for obstructive disease. So the moral of the story here is that for both non-obstructive and obstructive coronary disease, high-risk plaque features are associated with higher event rates. So this is an additive feature of plaque analysis software that we can use. And so there are a couple companies out there. HeartFlow is one of them, and HeartFlow is a company that Medstar has recently partnered with. So we're now using HeartFlow. And this is some early data from HeartFlow called the Fish and Chips trial. So in this study, they used their staging sort of plaque software, and it shows that green is low risk, red is high risk. So their staging criteria works pretty well in its ability to predict events. And this is after adjusting for risk factors, stenosis, and CT-FFR. CT-FFR basically tells you whether or not a lesion is hemodynamically significant. So this plaque analysis software is a powerful tool to not only understand someone's risk, but also guide downstream therapeutic decision-making. So now we're going to jump forward a little bit and talk about some of the newer things coming down the pipeline. We'll start with blood pressure therapies that are in development. I'm just going to focus on the RAS system here. So the first up is Baxdrostat. Baxdrostat is a novel aldosterone synthase inhibitor. So this comes from the phase 2 BRIGHT hypertension trial. It included patients with uncontrolled hypertension on 3 meds, including a diuretic. They followed them for 12 weeks to see how well did this drug work versus placebo. And so for both systolic and diastolic blood pressure here, if you compare to the placebo, you see a reduction in systolic blood pressure by about 11 millimeters of mercury versus 5 millimeters of mercury in the diastolic blood pressure group. I think this one is even more exciting. This is zilebesiran. Zilebesiran is a small interfering RNA molecule. So this is the same sort of technology that inclisiran uses. So it has a long duration of action, durable effect. So this is phase 1 data for this particular drug. It included both treated and untreated hypertension, randomized in 2-to-1 to receiving just a single dose, just one dose of ascending zilebesiran versus placebo. And if we just jump down here to week 24, this is 6 months after just a single dose of this drug, you see a reduction of 22.5 millimeters of mercury compared to 10.8 placebo. So durable blood pressure lowering after just a single drug is pretty exciting, particularly for patients that we know can't remember to take their blood pressure medicine, they can't afford it. All sorts of compliance issues. This is a drug that can potentially overcome some of those barriers that we deal with every day in clinic. Sort of along that same spectrum, we have renal denervation. Renal denervation was FDA approved just 2 years ago now as an adjunct to the typical blood pressure medicines that we're already using today. Now, renal denervation has actually been around for a long time. You have more than a decade worth of data, but it's really only been the last 5 or so years that the trials have been positive. So looking sort of holistically at how well does renal denervation work, Well, if you look at ambulatory blood pressure monitoring, it leads to about a 5 to 9 millimeter of mercury reduction. If you look at office blood pressure, it's about 9 to 11. So this is similar to maybe one drug. So, by no means is this a magic bullet. You have to be sort of temper expectations for patients that you may be considering this sort of therapy, but it works quite well and the efficacy is quite durable. So what do the guidelines say about renal denervation? Well, the ACC-AHA guidelines haven't commented on this yet. Actually, the new blood pressure guidelines should be coming out in a couple months. So it's very likely that they'll be commenting on renal denervation. So what we have now is the European Society of Cardiology Hypertension Guidelines. And, they gave kind of a weak recommendation, a 2B indication for renal denervation. It should not be used first line, and it shouldn't be used for patients with a low GFR. We just don't have the data for that population just yet. I'm going to skip through some of this for time purposes. I want to touch on incretin therapy. This is something that is very, very exciting in the preventive cardiology world. We've known for a long time that GLP-1s lower major adverse cardiovascular events in patients with diabetes. But what about patients that don't have diabetes? So this is the SELECT trial. SELECT is a game changer in my field. This is a trial that enrolled patients with overweight and obesity, existing cardiovascular disease. They excluded patients with diabetes, and they wanted to see if semaglutide lowers major adverse cardiovascular events. And the answer is yes. So if we look at the primary composite outcome, we have a 20% reduction in MACE with semaglutide versus placebo, improvements as well in heart failure, as well as death from any cause, all-cause mortality. This is the first weight loss drug to show a reduction in MACE. And I think the most compelling, interesting finding from SELECT is this. If you look at the Kaplan-Meier curves, you see a very early separation in these curves. That's important because you're not seeing clinically meaningful weight loss this early. You're not seeing a major reduction in blood pressure, improvements in cholesterol. You're not seeing any of that. So there's something unique about this drug that requires a lot more study. It's leading to the benefit. So this is quite an exciting time. And this is just the tip of the iceberg, right? You can't turn on the TV without hearing the Ozempic jingle in your ear. It's all over the place. And so there are a slew of other anti-obesity medications that are in the pipeline with various combinations. One of which I just wanted to comment on that I think is pretty cool. This is from the COURAGE trial, and this is some top-line data that was released by Regeneron just a few months ago, and this is testing a novel myostatin inhibitor. So this particular drug is trying to target the quality of weight loss. So we know that when patients lose weight on these GLP-1s, and really when they lose weight in any mechanism, a certain amount of that weight loss is muscle mass, right? About a third of weight loss from these drugs is lean mass. 2/3 is fat mass. So that's concerning for our older patients, right? We don't want to make frailty worse. We don't want to worsen falls. We don't want to induce sarcopenic obesity. These are some big concerns in the field right now. Well, this novel drug, which is a myostatin inhibitor, if you compare the drug to semaglutide, you get an 81% preservation of lean mass and about a 27% increase in fat loss. And so this is really, really interesting data that can potentially overcome some of the negatives of our current GLP-1 incretin-based therapies. All right, so nearing the end here, I just want to touch on gene editing, which I think is really, really exciting, something that may come along in our lifetime. So the reality is coming all the way over here, we do not a great job of controlling LDL cholesterol. And there are many factors that go into that. So in real life practice, you have a patient that comes in to see you, their LDL cholesterol is elevated. The doctor says, take your statin. Great. You take the statin, the LDL comes down. And then maybe a year or two later, they stop taking their drug. Maybe it's too expensive. Maybe they develop muscle symptoms. So you get this sort of yo-yo effect over the time course. So effectively, you're not adequately controlling LDL cholesterol. So some sobering statistics here. Only about 50% of patients with ASCVD are on a statin at all. Only 2% of eligible patients are on a PCSK9 inhibitor. Half of patients discontinue their statin at 1 year. That actually goes up to about 70% after 2 years. And only 3% of patients with heterozygous familial hypercholesterolemia, a very high risk group, are at their LDL goal. So our current drugs are just not cutting it. Well, what if we could develop a drug that durably lowered LDL cholesterol forever after one single dose? Well, that's what Verve is trying to do. So Verve is a company that was developed by Seth Kathiresan. He came out of the Harvard group, and he's interested in gene editing. And so what he's developed with Verve 102 is a lipid nanoparticle. Now, this lipid nanoparticle has a base editor within it. So it gets targeted to the liver, and the liver makes LDL cholesterol. And so once this lipid nanoparticle is endocytosed and into the liver, this gene editor is activated, and it introduces a single base pair change, an A to G change in the PCSK9 gene without introducing a break in the DNA. So this effective change leads to a stop codon in the PCSK9 transcript, so it effectively inactivates the gene. So this is sort of a one and done gene therapy to permanently turn off PCSK9 and permanently lower LDL cholesterol. And this is how well it works. This is just very, very early data from Verve. We have 3 different ascending doses here. At the highest dose group, this is just 4 patients. They've seen an LDL reduction by 53%. I couldn't find the time course for this. Of course, this is very, very early, but I think the implications for this are astronomical. This is the vaccine. This is the LDL vaccine. But of course, we need longer term data, more follow-up, et cetera, to see if this will actually work. So in conclusion, preventive cardiology is a subspecialty of cardiovascular medicine that focuses on risk assessment and optimizing therapies to lower risk. It's more than just lipids. It's all cardiovascular disease more holistically. On the population level, cardiovascular events are on the rise, and this is largely attributable to obesity and diabetes. We have a new risk calculator called Prevent, which is an upgrade from the pooled cohort equation. It gives you both a 10 and a 30-year risk for not only atherosclerotic cardiovascular disease, but also heart failure and cardiovascular disease more holistically. But it still requires real-world data. We don't know how well it's going to perform, and we need to understand what are going to be the thresholds for statin initiation. Lp(a) should be measured once in the life course, and hopefully by early next year, we'll know whether Lp(a) lowering translates to a benefit in MACE. Imaging should be used to understand risk when risk is uncertain. Imaging is always going to beat a risk calculator. And then the future, we sort of touched on some newer blood pressure medicines, incretin therapies, and then gene editing, potentially a one and done. And with that, thank you for your attention.